I have an answer to his question about, I was hoping that Mike would show up because I have a question about his insurance picked out provider for him. And I think that's a very reasonable question. And his question was, for people who just joined us, I'm going to one of these franchise providers. And what are your thoughts on that? And I said, well, in that this is kind of difficult. And so then I'm going to leave some stuff out. Thinking about it after the meeting, I said, you know what? We've given people criteria for how to judge the effectiveness of their hearing aid fitting. And you can use that sheet, and all people have to do is to send an email to me and I'll get it right out to them. And so they'll have some concrete criteria to judge their hearing aid fittings by. The other component of it, of course, and we talked about that before, was active follow-up. You've got to stay with it and keep going back to your provider until you've met, or your fitting has met all of these criteria that we suggest. So that's what I would say to him today if he was here. So having said this, we'll get started. I'm going to minimize my gallery, Zoom gallery, and this way I can just look at the camera and not be scanning all around to the various visitors. So I'm going to minimize it now and we'll get started. Okay, so everyone, welcome to part 3 of getting your hearing aids, what you need to know, at least in my opinion, and hopefully it's helpful for all. Just to review, I'm an ABD status. I do not have a PhD, but I've completed all the requirements except for the dissertation. So next we'll talk about, if I can get this thing to advance, do it manually. Okay. We'll review about part 2 and primarily the audiogram, because I think this is essential.
Did you hit your share screen button, Joe?
Oh, I don't think I did.
Yeah.
No, I got it. How do I get back to that?
You gotta re-energize your Zoom and then go down to the bottom and
Yeah,
hit the green share screen.
oh, now we're going to go through all kinds of stuff here. Thanks for reminding me.
Well, I didn't see anything, so I figured you skipped that step.
I did. I could go to full screen, I guess. Yeah, here comes share screen. Host disabled participant screen sharing. It's the message I get. Did you hear me?
Yeah, I can hear you, but if you hit share screen, it should show whatever's running in the background.
Well, I have the I have my gallery view and I have my slideshow up on
That's fine.
the primary monitor, but I don't have it on my monitor. So you know what? I'm just going to advance it manually if I can. So
Okay, well, I can't see it at all. So.
Oh, you can't see the show. Okay.
No. I don't know how important that is. But.
Yeah, well, I think it's pretty important because this is what it's all about. You know, we always have a snag with this, and with Chaz, we always get started early. This is a difficult issue for what we're trying to do here.
Yeah, on mine, if I get Zoom gallery full screen on my computer and then just say share, it shows whatever is running in the back.
Yeah, well, I thought I had done that. And
You just got to make sure that the presentation is running in the background.
well, we started with that. I'm trying to minimize the darn screen, or my mouse isn't happy. It's very jerky. I'm activating. I'm trying to click on the Zoom. Now I've lost the darn thing. Okay, now I've got the full screen. So I'll do share screen,
Yeah.
which I thought I had done. And it says host is disabled participant screen sharing.
Oh, that's in the meeting setup.
That's the message I'm getting here.
Yeah, I'm gonna try and make you the co-host.
Okay, I think that's what you need to do.
Yeah,
Yeah.
I'm gonna make you.
I see Bruce is nodding, so.
I'll make
Okay.
you the co-host and see if that cures the problem.
Okay.
Good.
Yeah, I think we're getting there. Now I think we're
There.
cooking. Now
Bingo.
we're cooking with gas, all right? It's
Yeah,
gonna think a little bit.
yeah. It says you've started screen sharing, so that's,
Yeah, okay.
Now we gotta find the screen.
there it
There we
is.
go. Yay!
Bingo.
Yeah, well, it's not quite bingo yet because I don't have my presenter view. And you know what? Let's just get along
Hit the
without it.
F5 key. Hit the F5 key.
F5?
Yep.
Okay, I can't even see it for crying out loud. That's a reset. I apologize, folks, for this, but this is always a pain in the neck.
We can
Now
go to the view menu at the top of the
It's-
slideshow. Start slideshow.
Oh. I don't know what it's thinking about. Okay, I see a black screen.
Can't trust these computers.
Yeah, it's still thinking. Now my screen on my monitor, my laptop is. Now I got the first screen. It's coming. It's coming along. It takes a long time to get happy. There it is. I think we're going to be good to go in a heartbeat.
Yeah, I can.
Okay, now we're all set.
Yay. All right.
And I'm going to minimize if I can get my mouse up there, the gallery view here. It's taking its time, but I've done it. Okay, so
Go.
are we all set?
Yep.
Okay, so now we are in part 3. And what we're going to talk about in part 3 is to present a brief overview of parts 1 and 2. And that's going to be really brief today. Overview of the anatomy. We haven't touched on that before, and I wasn't sure the best time to put it in. And discussion more of the audiogram, and present some difficult hearing losses, and provide an idea of, I think, of reasonable expectations and differences between audiologists and hearing instrument specialists, just touching on that again as a final reminder, then a final summary and the acknowledgements that are due to the fine crew that's put this together. So quickly getting into the audiogram, you remember the key points, right? The configuration gives you a great deal of information about prognosis for benefit, both in terms of the degree and how well you're hearing at the different frequencies. And we covered a lot of detail on the slide, on this audiogram. This is one of the most complete you will ever see. The most critical thing to take away, there's 2 points. One is the pure tone average. That's a very good indicator of overall benefit from amplification. And you can compute that yourself. And I think it's a good idea if that's not already appearing on your audiogram. And I think it's a very good idea to take the time to do that. And by the way, you should have a copy of your audiogram. By law, you are entitled to that. And ideally, your provider would have given you a copy of it. Take the average of 500, 1,000, 2,000, and 4,000, and that will give you an idea of the degree of hearing loss you have overall. Now, for individuals with high frequency hearing losses, especially sharply falling ones, that's a different situation. And the pure tone average might not really tell you the degree of handicap that you're facing. In that case, if you want, compute the average of 1,000, 2,000, and 4,000. That's what I would recommend. The next critical indicator is the word recognition score. And you can see this individual here has fairly good speech recognition in the right ear and quite good speech recognition in the left ear. Actually, they're really pretty close. Over here, you can see that with his hearing aid, he received 96, understood, was able to hear 96% of our critical test words in the word recognition test at 50 dB. That's the average conversational level. So he's really doing quite well with his hearing aids in an ideal situation with an ideal talker or speaker or recording. And you can see a summary of the amount of benefit he is getting. The B represents the amount of benefit with the hearing aid. The S is without the hearing aid. That means speaker or sound field. And you can see that he receives 30 dB aided gain and in the primary speech frequencies and 29 dB or so with his for the four speech frequencies that show up down here. Well, 3, 2K, 3K, and 4K. That's the high frequencies. So it calls out a lot of information. You can see that over here. Speech recognition, most comfortable listening level, and uncomfortable listening level. That too is important. Some hearing losses present with a tolerance difficulty for loud sounds. Word recognition score in review is an indicator of the integrity of the inner hair cells. And you'll see a slide coming up that points out how it does relate to the hair cells. Low scores of word recognition score suggests an inner hair cell damage, and you'll see what we mean by that. Although on rare occasions, initially the presentation level of the test words is too low to get an accurate reading, but it's still a very good indicator of how well someone is likely to do. If your word recognition score is down, full satisfaction could be very elusive to attain. And it's not because of the hearing aid, but rather because of the status of the inner hair cells. And hearing aids cannot overcome this. It can't be done. Some, as we've said earlier, degrees or types of hearing loss are much easier to assess. Those that are sloping or flat, sloping downward or flat, or even slightly rising they can be easy to manage, and they're usually ideal or very good hearing aid candidates if they fall within the moderate to moderately severe range. Some can be a lot more difficult. The one that comes to mind the most is a sharply falling audiogram, and any grades in between are more difficult. Sawtooth or peaks of poor hearing. I think Bruce has a sawtooth type audiogram. That makes it very difficult to find the sweet spot where it's comfortable for people. And then some individuals, and we'll see an example of that coming up, actually have dead zones in the cochlea. That means there's no active functioning outer hair cells, maybe even inner hair cells. The most ideal candidates, obviously, are those with the better hearing. Mild to moderate, maybe 25 to 50 to 60 dB. Pure tone thresholds almost always do well with their hearing aids. That means almost always their word recognition score. Almost always they don't have a sound tolerance problem. Moderately severe to severe, these individuals receive good benefit. Now that means that their pure tone average is down to 70 to 85 dB. So that's a pretty substantial hearing loss. And with these two ranges, we've encompassed the vast majority of people with hearing loss. Severe and profound degrees of hearing loss, as you recall, that's 95 or 85 to 90 and what have you. It becomes more difficult. Now, once in a while, there are individuals that are down at this level who do great. But more often than not, that's not, unhappily, that's not the case. And the deaf individuals, they usually don't provide much benefit for understanding words, but they are very crucial for keeping us in touch them with their environment and things that are going on around them. In terms of word recognition score, obviously 90 to 100% is ideal. All the way down to 60% or less. Then it becomes pretty difficult for individuals to receive good, satisfactory benefit from their hearing aids. For their entire career with amplification, I've had patients who keep saying they need to do a better job with these hearing aids, failing to understand the issue of the integrity of the inner hair cell, and then of course the whole acoustic anatomy. Let's start with a review of the acoustic anatomy. Now, we've all heard of the inner ear, outer ear, and middle ear. So the outer ear, see if I can get my mouse up there, consists of the pinna, which is the part we all see, which serves to gather and conduct sound energy in our environment and transmit it through the ear canal to the eardrum. The eardrum captures that sound and it converts it to mechanical energy and conducts it to the three bones of the ear. The three bones of the ear actually amplify the sound energy that's heard and present it to the inner ear or the cochlea. This is where the sensory nerve endings are, and they attach to the auditory nerve, which exits through and into the cranium. A problem along here, excuse me, is called a conductive problem, and a problem in this region is called a sensory neural problem, often abbreviated as a nerve loss, because that's fewer words and it's easier for people to remember. The inner ear consists of three canals: the upper canal, the middle canal, and the lower canal. The organ of hearing is in the middle canal and is very, very small. It consists of 3 rows of outer hair cells and 1 row of inner hair cells. You can think of the outer hair cells as being the tuning mechanism for understanding of speech. If these guys are distorted or messed up, it's going to be hard to get a good, clear signal to the nerve. These processed sounds, if you would, are then passed over to the inner hair cell here. And think of this as the amplifier. I don't know if that's true or not, but it's a good way to schematicize things. That then will pass the sound into the auditory nerve, and from there up through the auditory system to the cortex. Let's take a look at the normal hair cell arrangement. So you can see that the outer hair cells here consist of 3 rows, and they're all arrayed in a tonotopic way. That means think of tones. Starts with the low tones at the very end, and the high tones, the high pitches at the very beginning of the coil and the cochlea. These then feed impulses to the inner hair cells, which is, we decided to call them, for the sake of discussion, the amplifiers, which then pass them on to the auditory nerve. There are approximately 15,000 of these outer hair cells and 3,500 of the inner hair cells in each cochlea. Now, this is a view of damaged outer hair cells. And you can see how terribly distorted the outer hair cells are, or missing. Those that remain are really quite damaged. And looking at the inner cells, they're still pretty much intact. So my sense for the hearing for this person, and I could be wrong, but I think it's a reasonable guess, is that this person hears a lot of sound, but it's not as clear or very clear as we'd like it to be. I have a sense that you can get along without all of these cells being healthy and normal, and just function to a degree off of the inner hair cells, but I've never read anything about that. That was a favorite topic of mine when I was in grad school. So we reviewed the audiogram. Some configurations make it more difficult to use amplification. Sharply falling ones come to mind: sawtooth or peaked, steeply rising this way, or the left corner audiogram, which we've never talked about, but that's, I think of results only being in the very lower bottom of the audiogram at frequencies of 1,000 or less. This is what we frequently see for individuals who have severe deafness. And according to severity, very severe hearing losses are more difficult, and it really leaves you with a limited range of residual hearing for squeezing all of the sounds in the environment into the residual hearing for that individual. And word recognition score, if that's down, satisfaction can be elusive for some hearing losses. When we're talking about squeezing everything into the range of residual hearing, what we're really talking about is dynamic range. And the dynamic range is the difference between the threshold of hearing and the threshold of discomfort. Surprisingly, the normal threshold of discomfort of 120 dB can become truncated or reduced substantially for individuals with a substantial sensory neural hearing loss. So the dynamic range is very important for understanding some of the limitations of amplification. As we've said before, it's easy and really inexpensive to make sounds louder, but it's hard to do that without making them too loud and attempting to maintain the critical intensity and acoustic differences between the various speech sounds. That translates as more costly. In terms of reasonable expectations, users should do well if they have mild through moderate hearing loss levels, and if they have a gradual sloping hearing loss, and good word recognition score and no tolerance problem. That's almost an automatic favorable outcome. We all like to see those kinds of audiograms. So in review now, we've talked about it a lot, but it's so critical. You need to know things you need to know about as a hearing aid candidacy to judge how well you might do. First is severity, how far down on the grid you fall. Configuration, what is the shape of it? And your word recognition score. These three items can give you a good idea of prognosis with amplification and how severe your hearing loss is. So with this information and the criteria that we presented in our last talk about how to evaluate your hearing loss, then you should have a pretty good idea of what to expect from your provider and from your hearing aids. As we said, we called out the pure tone average, and the legend is critical. Every audiogram has a legend on it, speech recognition scores, and the other measures. And we talked about the importance of word recognition. Here is an ideal candidate. This is a person with a mild hearing loss. And actually, this individual might be a reasonable candidate to pick up a pair of hearing aids online or over the counter and do fairly well with it, because there's no critical variable there that would negatively affect performance. And it's pretty easy to pick up 5 or 10 decibels here, or even 20 in the higher frequencies, and notice a significant improvement. This person has 100% word recognition, no problem with tolerance. Now here's a mild to moderate loss. This is what we're talking about with most over-the-counter hearing aids. This is a 35 decibel pure tone average with 100% word recognition, and again, no tolerance problem. Should do quite well. This is mine. We talked about that before. And notice that I have an island of good hearing at 1,000, and then it drops dramatically down in the critical speech frequencies. With my hearing aids, and I have the best around, I still miss the high frequency sounds in everyday conversation. I still have problems with individuals with a higher frequency voice and maybe a soft voice. Soft voices are always going to be tough. I had a terrible time with my grandchildren when they were young. And the only way I could get over that was to make sure I had an interpreter nearby. I tried everything I read, and it just didn't help. Young kids don't have their language skills well formed, nor their articulatory skills, and their pacing is way off. It's really hard to pick up what a young child is saying. There are some limiting factors for successful hearing aid use, and we've talked about a lot of them. Word recognition score, tolerance, configuration of audiogram, and severity. Advanced age is another factor. That's a big deal, because as we age, our auditory neurology, as well as the rest of the neurology in our bodies, slows down. As it slows down, it means it takes longer to get the information up to the cortex. Not only that, but it tends to become I can't say the word, asynchronous. There are so many stops along the way to the brain that I don't think most people realize. Well, each one of these stops adds time to the signal reaching the cortex. And it can take upwards for an older person, such as myself, a full a second or maybe a second and a half before all that information gets up to the brain. So even if my sensory apparatus is able to pick up all the sounds, it takes a while for them all to get up to my cortex in a coherent way. Another real issue with hearing aids is too small of a hearing aid. There's not enough room for all the proper features or feedback issues. So my advice is don't try to hide it. Don't try to hide it. And when I was in practice, I lost a few potential patients because I was not in agreement with providing them with a little tiny hearing aid, especially if they were older. In terms of the younger adults who came into the office, I mean 20, 30 or so, that's not so critical because their auditory neurology is, of course, in much better condition. Now, this is a fellow who could not really come to grips with the fact that he wasn't hearing clearly. He was displacing his word clarity issue that was inherent in his ear to every provider he ever came in touch with every person he communicated with every day. And he just thought that people weren't talking as clearly as they used to. And in the middle of one of our tests, the first time, he said, "You're not speaking clearly." Well, I corrected him, and I had already looked at the previous results he brought in. Every other provider had shown him that he had a reduced word recognition score, but it didn't register, and that it was worse in the left ear than the right. Well, it turned out we found exactly the same score. So after that, he became convinced that maybe there was something going on with his ear. And this is another person who, he was really a nice guy. He was a great guy. And he had this peak of hearing loss, or this island of hearing loss at 2000. And you could see it was very difficult to find the sweet spot for him because he needed the amplification at 2000. That's worth 33% of intelligibility. That's very important. And yet it's hard to provide amplification here and not over amplify these adjacent frequencies, even with all the bands and channels and fine tuning. You know, all that stuff, all the fine tuning winds up at the receiver where it's all averaged out, and it's kind of spread out along the receiver. And so in spite of all the fine tuning, it still was not satisfactory to him. And we were never able to find a nice spot for him. And here's a difficult hearing loss. This patient, her name is Stella. She was great. She lived to 104 or 105. And she was feisty every time she came in, but in a friendly way. And she was one of our favorite patients. But look at the task that her hearing aids were presented with. How is she ever going to get all this information down here? She's never going to do it. Most hearing aids can do 30 decibel gain. Now, we do see that in some instances, when hearing loss gets down here, something happens in the inner ear. And very often, not very often, sometimes we will see a tremendous improvement in amplification benefit. It's almost like there's this magic threshold where all of a sudden, wham, something's released in the inner ear, and then the amount of benefit from hearing aids increases dramatically. This is part of that unanticipated interactive effect that we've talked about. Now, here's one of the most frustrating audiograms for any provider. This is Jim. Jim was a great guy. We got along fantastic. Notice it just drops precipitously. That's not uncommon in men. I don't think I've ever seen that in women. I kind of call this male pattern hearing loss, you know, and it can be at different frequencies, but it just drops sharply. Now, we mentioned earlier about the dead regions of the cochlea. This is a good example. This is probably a dead region. The response here, probably not really a response to 2000, but instead a response to 1000 because of the spread of the tails of the power spectrum for each frequency. So his hearing probably ends up here at 750 or maybe at 1000. It's hard to say. Point is, there's really no usable hearing at this frequency or that frequency either. And a hearing aid is not going to help this poor guy. Look at his scores though. He too was never satisfied with his hearing aids. He had a 56% word recognition score, a decibel hearing loss, pure tone average, with a word recognition score. I think this was with his hearing aid. I'm forgetting. I should have looked at this a little bit more closely. But he got great improvement with his word recognition score. Okay, moving up to 92%. So the way I would have gotten the 80% score is to test him at a very loud level. He wound up getting a score of 92% with his hearing aids in an ideal listening situation. Now, I don't remember if I did that at 50 or 60 decibels, but he was getting some magic benefit. And again, we get back to that unpredictable interactive effect. Now, I really didn't test his word recognition score without his hearing aids in a sound field. I'm just guessing at this because that would have been way too frustrating for him. But he had a fantastic outcome, but he was still missing so much that he was never satisfied with his hearing aids. And this points to what's going on in the hair cells. Once again, this is the normal array and a normal peering array of hair cells. And over here are the damaged cells. Now, I would bet that this is what his inner ear looked like for the higher frequencies. Some good hearing here, some good hair cell integrity for the higher, louder sounds, but nothing here on the outer hair cells. But of course, he can't see that, can he? He has no idea what's going on. So I came up with the analogy of the baseball glove for him. And I like this. This is a very good analogy. Every young kid probably had a baseball glove. And every young kid or every person who's ever had a glove knows that it's so much easier to catch a ball with a baseball glove than without. And let's say that through an unfortunate circumstance, these fingers here got cut off in an accident of some sort. So then the person puts on the baseball glove. Are they going to be able to catch the ball as well as they did before? No, of course not. They just don't have all of the parts of their hand available. Are they going to blame the glove? No, of course not, because they can see the reason for it. But when it comes to hearing aids, you can't see those missing hair cells. You can't see that critical part of the auditory system that is missing or highly distorted or highly damaged. And so who or what do you blame? Of course, you wind up blaming the hearing aid, don't you? You think that the hearing aid ought to make your hearing better. And you can't really see the reason why that doesn't happen. Now, in the case of high frequency hearing losses like this, and Jim's a good example, And somebody here in attendance is a good example of it. Sometimes the best judges of benefit are the communication partners and family members. Because in some instances, other people are more affected by the hearing loss than the person who has it. And why is that? Because of course, the first time you don't hear it, the other parties make it louder, repeat it, restate it. And this happens 2, 3, 4 times till you get it. The person with a hearing loss says, well, if only you spoke that way in the first place, I wouldn't have a problem. But of course, they don't realize all of the work that the other parties are doing in trying to communicate with them. And usually, it's a good thing to keep in mind. If somebody points out to you that you've got a hearing loss that needs help, this is especially true for beginners. People just don't go around pointing out other people's problems because it ordinarily doesn't affect them. But hearing loss constantly affects people around you, both in terms of their abilities to communicate with you and in terms of things in your acoustic environment. Your television is so loud or much louder than they would normally have it. And it bothers them all the time to have to live in that noisier environment. So if your communication partners suggest that you're receiving benefit, you probably do receive benefit, especially for individuals with high frequency hearing loss. Again, just reviewing the limiting factors: degree of hearing loss, configuration, word recognition, advanced age, and then let's throw in all the non-auditory factors. We haven't talked about them much, but they're very operative in many people, especially older people. Manual dexterity, loss of sensation in the fingertips. I'm getting that. And after all these years, it's getting harder for me to place the receiver in my ear canal. Vision, motivation. If you don't see well, it's hard to change the batteries and manipulate your hearing aid. Various anatomical consideration. And another large part of it, of course, and we've all seen it, is motivation. And how desirous are the users of getting an amplification device. Having said all of those negatives, though, there are a lot of things that we can work on. One, of course, is loudness. You can always make sounds louder, as we said. And we can typically make sounds more clear through proper adjustment of the hearing aid, which of course is dependent upon the loudness level and the configuration of the audiogram. But 100% of the time, people hear better with their hearing aids in quiet than without them. That's our gold standard. That is always present. Voice quality, this can be troublesome for new users. I don't think people expect to hear themselves differently. And as soon as you plug your ear with something, it changes the whole quality of your voice, the whole resonance patterns in the inner ear. I'm sorry, in the canal. And it can be difficult to accommodate that. Your provider cannot eliminate that, but they can make it better. Or I shouldn't say cannot, may not eliminate it entirely, but they can make it better. So you shouldn't be ever walking around with a problem like, they plug my ears, it's uncomfortable, it doesn't sound right. And yet I encounter lots of people who complain they have that problem. And that's one of the reasons they don't wear their hearing aids. You have to keep going back to your provider again and again to have your provider resolve this. There are lots of tools in everybody's tool case nowadays to help improve this voice quality issue. Comfort. They should always be comfortable. You should be able to wear your hearing aids all day without wanting to yank them out at the end of the day because they irritate your ear canals or hurt your ear. And we've said before, there should be no distortion. They shouldn't be splattery or fuzzy. One of the things that providers do, this is an aside, is to implement the feedback manager. That's a great term, but what it really means is they are cutting down on the very critical high frequencies that are necessary for proper understanding of the sounds and words in your environment. This is a very poor, in my opinion, I have a strong opinion. This will make everybody angry with me, all those providers out there. And I have some concerns about telling you this, but this is not an optimal solution. They do that primarily because they need to trap the sounds in your ear. And that's what leads to that voice quality issue I talked to up above. You can manage the voice issue almost all of the time without having to implement the feedback manager. That was my experience. Almost always, you receive more functional hearing in noise. Many people, experienced users more than beginning users, say they don't like the noise. They can't stand the noise. It's so bothersome. Well, of course, your hearing aid turns up the noise as well as the sounds you want to hear. That's just the way it's going to be. It's better now than it ever used to be. But the one thing to keep in mind is that everybody reports they hear much better in noise with their hearing aids than without. What I heard throughout my practice was, I sure don't like the noise, but I wouldn't hear anything without my hearing aids. And this is where the volume control becomes very critical. When you're in a noisy situation and the noise is too loud, turn your volume control down. Now that will ordinarily work, and here's why. Because the other people in the environment are bothered by the noise too. So what are they going to do? They're going to raise the volume of their voice. So that automatically improves the signal to noise ratio for you. Then in terms of active follow-up, which we've talked about before, you might want to talk about loss or damage insurance if you're concerned about it. We rarely recommended it. Most people don't lose their hearing aids. So it's an additional expense. It's just something to consider. However, if it's a high risk situation, you may very well want to think about loss or damage insurance. But it's like buying a car. Don't start paying for that insurance until the warranty ends, okay? Why would you insure a car for breakdown if it lasts for 3 years under warranty? That's not when your problems occur anyways. It's later on. So that's the time to buy the insurance if you want it. Always try to seek a 6-month check. Remember, we're talking about active follow-up. And a reevaluation and hearing aid check in 1 year is a very good idea to make sure that your hearing is still suitable for the settings that your hearing aids are at, and that no minor problems or distortions have crept into your devices. And just stay in touch with your provider. Let them know how you're doing. There are some things that are just plain difficult to overcome. And, you know, primarily it's hard, what I call hardcore noise, restaurants, weddings, parties, sporting events, loud gatherings. You can develop strategies to deal with that. I asked somebody once how they dealt with a wedding, and they said, I always ask people to go out in the hall. And they say, and I asked them, can we go out here so I can hear you better? I'll be very explicit about it. And I thought that was a great suggestion. Then, of course, there are a wide array of assistive devices. And we don't have the time to talk about them much in this setting, but HLAA Rochester chapter has a really great assistive device demonstration center where in times of non-COVID, you can go in person and visit, or you can attend virtually. And you can go on our website to find out when these sessions are held. I think they're usually the third Thursday of each month. In terms of what you want to get with your hearing aid, you want a volume control. Many providers will insist you don't need them, but I think every experienced user here, at least at HLAA, feels they are of critical importance. And I do too. I use mine constantly. You do want a T-coil. Initially, when you first get your hearing aid, that might not be a primary concern of yours, but you don't know when they will come in handy. Both the addition of a volume control and a T-coil are not expensive. There is, however, a loss in the miniaturization possibilities because you need room for those items. And I don't think that matters today. Nowadays, the hearing aids are so small that it's not going to be a major factor. And of course, you want a program selector. This is pretty standard. I would advise you not to let your provider say, well, we can handle the volume control issues by adding a separate program for you. I think you really do want a separate control for your volume control. In terms of getting used to background noise, I think this is a very interesting group of slides here. There are two primary issues. One is if it's overall just plain too loud and is physically or acoustically uncomfortable, you should have your hearing aids turned down. Don't put up with it. I would get a return visit to my provider right away and request that the volume be turned down if you don't have a volume control. And then you can bring it back up as your ears begin to develop tolerance to listening to louder sounds again. And the other thing is that general background noise will be very distractful at first, but you do get used to them. And I'm talking about the lower level sounds like your refrigerator or most traffic noise or sounds around the house or just everyday activities. These sounds are in your environment and you will adapt to them and they will return to the subconscious level where they were before you got your hearing aids. In terms of getting used to environmental sounds around you, the most important thing you can do is to use your hearing aids all day, every day, from the very beginning of the day until you go to bed. And if the ambient noise is too bothersome, then this is where your volume control comes in handy. Turn them down a bit and then contact your provider right away and have the hearing aids reduced, the gain. This should be a short visit. I don't think it should be counted as a return visit. That's my opinion. There's some noise intruding on our session here. Brain hearing. And this is a term we hear a lot these days. And it is true, but I don't think many people fully understand what that really means. The brain hearing actually takes place largely in the brainstem, perhaps in the cortex, where there are many auditory neural way stations, and all the way back to the level of the hair cells in the inner ear under certain circumstances. And in terms of environmental noise and background noise, you can think of hearing as being meant to respond to minute auditory changes in your everyday environment. Just like we react very readily to changes in our visuals seen. If something moves, we know right away that that's different from what is the normal experience. We are constantly and unconsciously monitoring things that happen in our environment, in our acoustic environment, outside of our direct field of vision. And hearing is meant to be super responsive to new or different stimuli. And it serves to trigger our fight or flight reflex, which is inherent in every being. If there's something new or different, you need to assess whether or not it could be harmful to you. However, the brainstem serves as a filter to the cortex, and it can retard or enhance auditory input to the cortex, and it can activate or initiate the fight or flight response. And the end result is there's a state of tension until the novel acoustic stimuli becomes adapted to or habituated, which is associated with increased heart rate, changes in blood pressure, increased glucose metabolism, and increased behavioral alertness. So it's supposed to work that way. However, with exposure, it will go away. I'm going to show you an example of some of the known auditory pathways in the brainstem. And everyone knows that auditory impulses travel to the cortex where they are perceived. But what people may be unaware of is that they are modified along the way. And it can take a long time, up to a full second or a second and a half, maybe 2 seconds, to have all of the auditory impulses reach the cortex. And we've all experienced that, where you don't get something that was said right away, but then maybe a moment later, it makes sense. But not everybody knows either that these way stops along the way to the brain also send impulses back down to the pathways, right to the cortex. I'm sorry, right to the inner hair cells, the outer hair cells. And this contributes to the fine tuning of the auditory impulses. Here's a great example of some of the way stations from the cochlea to the cortex. Now, let's start here at the cochlea. Sounds come in, and they are immediately broken down into 3 components of the dorsal cochlear nucleus and the posterior. I don't even know what V stands for. Cochlear nucleus. Then it goes up, and then it comes over, and then it will get to the cortex, or maybe it'll go straight up. So you can see how there can be such a splattering and such a delay in the transmission of impulses to the cortex. And as we get older, of course, all the neural activity slows down for a variety of reasons. Now, some really clear, measurable effects of brain hearing would include distraction and inhibition. And these phenomena can actually be observed and measured. This is a great example of distraction. Here we have a very, very, very hungry cat that's in a box, okay? And he has an electrode attached to its leg. And you can see when the electrode delivers a minute electric shock, of course, the cat is aware of it, but you can tell by the demeanor of the cat, he's not alarmed. But there is a huge response here, okay? Now, then the examiner introduced the odor of food into the test chamber. And all of a sudden, that neural response totally disappeared, went away. The cat no longer perceived that very minor electric shock that it was experiencing. Then the odor of food was removed and the stimulus was reapplied, and look at this huge response now. It's even greater than it was before. So that just gives you an idea of the power of distraction. And this happens in the brainstem. This is just so amazing. In our next slide, if I can get to it. Aha. See if I can bring my thing down. There it goes. This is habituation. Now, these are results for a pig. And the pig was exposed to an auditory stimuli, a click, like this. And they use clicks because it's easy to identify the response and measure and to quantify. And initially, when the click was present, there was a very large response. However, over time, the pig soon learned that this response meant nothing. The stimulus meant nothing to it. There were no consequences. So it became habituated to the sound. And these two neurological examples are exactly what happens in the cortex or in the auditory system as adaptation and habituation occur, distraction. So there's no doubt that it does happen, but in order for that to happen with hearing aids, they have to be worn full time. The very best place to use your hearing aids are around the house, where there's lots of everyday sounds and noise. Ordinarily, you have total control over the sounds in the house, and that's great for adaptation. And you can take this to the bank. Your hearing aids will not work out of the house. Your ears have not had a chance to adapt to the sounds in the house. And as a provider, I heard many stories. I only use them when I need them. I only use them when I go out, but I can't stand the noise. These darn things, they don't work. That's so repetitive. And of course, if you're not wearing them at home, you're not going to be able to do well when you're out of the house. So in summary, hearing aids are much more complex than most individuals envision. And hearing aid use is more complex. In addition, and we've talked about this before, but we can't overstress it, in addition to amplifying sounds, they are also sound processing devices. And they replace, they're trying to replace the role of the sound studios and audio engineers in those sound studios with very tiny, low power digital electrical sound processors with up to 20 channels. Each channel, which is not unlike really a separate hearing aid. It's not just a graphic equalizer, it's a separate circuit almost. Constantly monitoring the acoustic environment and selecting the best possible array of electronic conditions for the listener based on their individual hearing loss. In this whole process, the most important aspect of use, however, is not the device, it's the provider. It's the provider that knows what to do with it that makes all the difference and has a desire to have the individual do, the user do as well as they possibly can. There are major differences between the two classes of providers. The commercial sector, which is a sales profession, and is regulated solely by the New York State Department of State. And it takes only one exam. We talked about that before. Professional sector, on the other hand, is a doctoral program and is considered to be a health-related, service-oriented, mission-driven profession, which is regulated by the Department of Education and various professional societies, as well as the Department of State. Keep in mind that when you get a hearing aid, you are not just buying a device. You are entering into a long-term relationship that could potentially last 5, 10, 15, 20 years, maybe longer. possibly for the rest of your life. And keep in mind, this is an important statistic, that there is not good agreement between the relationship, between hearing aid satisfaction and satisfaction with a professional that provides the hearing aid. Traditionally, overall satisfaction has ranged 50 to 70% with hearing aids because of all those reasons we just got through talking about. Whereas approximately 94% of users are quite satisfied with their provider with very high rankings. The highest rating was 96% satisfaction, professionalism, and the lowest was explanation of expectation. This has been repeated time after time after time. So what this means is that the user likes their provider and thinks their provider is doing a great job, but yet the satisfaction rates vary considerably. So if you like your provider, that's wonderful, but don't automatically assume that they have always optimized your fitting at the very beginning. One of the comments I frequently encountered when I was going to professional meetings and all, question would come up, do you do any measure of your outcomes? And the response would be, no, I don't need to. My users would tell me if I'm having a problem or if they're having problems. But yet we know, ironically, that 50 to 70% are dissatisfied with their hearing aids. So hearing aids are not at all like smartphones or portable CD listeners, iPods, Walkmans, and so on. They're entirely different. And there can be unpredictable interactive effects between the user, their hearing loss, and their hearing aids. And that's very important. Now, sometimes it can work out in favor of the user. Sometimes it works in the opposite way. So when you get a hearing aid, as such, if you can possibly do it, consider a fully bundled service package as against the lower cost 1 or 2 visit concepts that are out there that many insurance plans now provide. It's very limiting. Or if that's the option you choose for, that's great. But just be prepared to follow up and pay an additional expense if you're not doing well, because your provider is not getting a very good margin at all. I can guarantee you that. And they just are unable financially to be able to support the additional services without asking for a fee. And remember the key difference between liking your provider and liking your hearing aids. And again, not every hearing loss has the potential for full satisfaction with a hearing aid. Due to physiologic limitations, meaning all the things we saw about the nerve cells. But every user is far better off with a hearing aid than without them. There are some things which never should be a problem for you. And finally, of course, keep in mind that hearing aids can and do help. Before we go, we need to thank our technical staff, Charles Johnstone, Dan Brooks, Lauren Gallstell, Eric Madsen, for all of their help with our with this program. This could not happen without their valuable assistance. And of course, our chapter president, Art Maurer, whose vision and insight brought this particular program forward. Keep in mind that better hearing equals better living. So with that, now we can ask questions. And I think we could end our recording. So I can